ECG interpretation forms an integral part of your Part 1 curriculum. This series of 4 lectures gives you a basic introduction to the interpretation of ECGs. It is not intended to be all comprehensive, but should allow you to provide a structured approach to the diagnosis of 12-lead ECGs and come up with a reasonable differential diagnosis of the common things that you're likely to see. At the end of the lectures, you will be able to utilize a systematic approach to ECG analysis to describe the normal ECG, to identify common abnormalities in rhythm, in QRS complexes, and in the ST segments. And the approach we're going to use is this. First, we're going to look at our patient, then diagnose the rhythm. We'll have a whole lecture on rhythm diagnosis in the 4th part of this lecture series. Look at the QRS complexes, the axis, ST segment, and then finally the P waves, and looking for any abnormal or ectopic beats. When we ask about the patient, the first thing we ask is does the patient have a pulse? Clearly, if the patient is pulseless without signs of life, we have to go into cardiac arrest mode and implement our ACLS protocols. If the patient is not stable, our first priority is to stabilize the patient before we start pouring over our ECG. And if the cardiovascular system is not normal, then we need to deal with that while we look at our ECG. It's also important to think about the patient's clinical history and examination, as this may give us clues to what the ECG is showing us. Things like chest pain, shortness of breath, syncope may be very important in interpreting the ECG in front of us. For the rhythm diagnosis, we will spend an entire lecture, part 4 of this series, on rhythm analysis. So here's the cardiac conduction system. It consists of a series of conducting fibers that form a structured pathway through the heart and ensure that any depolarization wave goes through the heart in a structured way, leading to coordinated contraction, atria, then ventricles. All these conducting fibers have automaticity. That will say they'll fire off on their own. And what really controls them is whichever fiber is firing fastest in normal conditions. That's the SA node. If at any point the higher nodes like the SA node or AV node shut down, then the firing will take place lower down. Alternatively, sometimes lower fibers get excitable and start firing faster and produce rhythms, sometimes generated from lower down, like ventricular tachycardias, for example. In the normal scheme of things, the P wave is generated from the SA node and then leads to depolarization through the atrium. That's the P wave. When the conduction reaches the AV node, it's halted there or slowed down at the AV node, and that produces your PR interval. The impulse then goes down the septum and back up through the ventricular wall, and that leads to your QRS complex. And finally, as the ventricle repolarizes, you get a T wave. The normal QRS complex is less than 2.5 small squares, less than 0.12 seconds in width. It is not smaller than 6 millimeters in leads 1, 2, and 3, and not taller than 25 to 30 millimeters in the precordial leads. In the precordial leads, you see something called R wave progression because of where each precordial lead looks at the heart from. So it goes from predominantly negative in V1 to positive in V5, 6, and usually V5 is a little bigger than V6. That pattern, as you see on the slide, is what we call R wave progression. This is R wave progression. If there is any disease of one or the other half of the conducting system through the ventricles, that is one of the other bundles, then you get wide QRS complex with specific patterns. So if the left bundle is slowed, then the left ventricle depolarization occurs a little bit later than the right ventricular depolarization. That leads to a deep slurred S wave in V1, and a wide notched R wave in V6. Whereas in right bundle branch block, you get an RSR pattern in V1, and that's because that second R is right ventricular depolarization, which has now occurred somewhat later than the depolarization with the left ventricle. And then in the V6, you get a slurred S wave, and that slurred S wave represents the delayed depolarization of the left ventricle. So these patterns, you need to learn them and identify them when you see them on a slide. And in fact, here's one. So this is a broad, complex QRS, and if you look at the ventricular precordial leads, you will see that what you have is a deep slurred S wave in V1, and you're not seeing much of V4, 5, and 6, but if you will, you would be able to make out an RSR pattern. Another abnormality that you can see in the QRS complex is with Parkinson-White, which is because there's an accessory pathway to the ventricles that can lead to early depolarization of the ventricles. And this produces a little wave, this accessory bundle, a little wave just before the QRS, which broadens the QRS. And these are called delta waves. You can see them quite clearly here. If you do have Parkinson-White, there's a risk that this can lead to atrial fibrillation because of uncontrolled entry of impulses through both the AV node and the accessory pathway, which can lead to which can then cause a retrograde circuit movement between the accessory bundle and the AV node, ultimately leading to atrial fibrillation and a broad complex irregular tachycardia, which is the hallmark of Wolff-Parkinson-White paroxysmal broad complex atrial fibrillation. It's broad because the irregular impulses are coming through the accessory bundle and therefore can't follow the normal pathways of repolarization provided by the ventricle. We're just going to talk a little bit now about the QRS axis. So the QRS axis kind of tells us which way the part is pointing and which way the QRS complex is moving generally, the main direction of movement. Usually this is between minus 30 degrees and 90 degrees. If it's less than that, it is left axis deviation. So most left axis deviation will be between minus 30 and minus 90. And if it's more than that, so between 90 vertical and 180, we have right axis deviation. So how do we actually estimate the QRS axis? First thing you do is identify the lead with equipotential QRS complexes. In this example, that would be lead 3. Then look for the axis at right angles to this lead. So let's go back. The axis at right angles to lead 3 is either AVR, or the closest next one that we look at is lead 2 or 1. And the one that is most positive represents the direction. And as you can see, leads 1 and 2 here are positive, but AVR is negative. So this is a normal axis because it lies somewhere between lead 2 and lead 1. There's a little shortcut way to look at this. If your lead 1 and 2 are both positive, it's most likely a normal axis. If your lead 1 is positive but your lead 2 is negative, that suggests left axis deviation. However, if lead 1 is negative and lead 2 is positive, that suggests right axis deviation. These are some of the common causes of left axis deviation. If the ventricular muscle is bigger than it should be, left ventricular hypertrophy. If there's slowing of conduction to the left ventricle, left bundle branch block or left anterior fascicular block. If there's ischemia, inferior wall MI, or if the heart itself is more horizontal, so it's actually pushed upwards, which is on axis basis pushed up into the left, like in pregnancy or in short fat people. All these things can cause left axis deviation. Whereas in right axis deviation can be seen with the opposite, right ventricular hypertrophy, slowing of the conduction to the right side of the heart in right bundle branch block or left posterior fascicular block, lateral wall MI, or right ventricular strain patterns, either chronic as in pulmonary hypertension or acute as in pulmonary embolism. There's one other we didn't mention, which is in tall, thin people. They also have the heart tend to be hanging more vertical, and that produces right axis deviation. So if you have any questions, you can post them on the WhatsApp page or ask them in class, and we'll try to answer them. So again, just in summary, this is the systematic approach we use. How is the patient? What is the rhythm? QRS complex, QRS axis, ST segment, P waves, and then abnormal or ectopic beats.